So many researchers have turned to finding a cure for COVID. So this is probably the most concerted effort that I've ever seen in the last 20 years, where we are all working towards a common goal. Mm-hmm. And I think that is truly exciting. It's really brought the research community together.
Welcome to Living Transplant,
the podcast that takes you behind the scenes of the transplant program at Toronto General Hospital
and brings you open and honest conversations about the transplant experience.
My name is Courtney, and I'm the communications specialist for the Centre for Living Organ Donation.
And my name is Brittany. I'm a bedside nurse in the Ajmera Transplant Centre.
Full disclosure, we are not physicians.
No, and we are not here to give you medical advice.
Think of us like your guides through the world of transplant as we know it.
Whether transplant is your past, present, or future, your passion, or your curiosity,
Living Transplant will show you the world of transplant like you've never seen it before. This episode was recorded in June 2020. For the most recent updates on COVID-19, please check the Health Canada website. If you have specific transplant-related questions, contact your transplant team.
So sit back, put on your mask, and enjoy this episode. Today we have Dr. Kumar here. She's an infectious disease doctor at the Ajmera Transplant Centre. Thank you so much for coming.
Thanks very much for having me.
Yeah. So first question, why did you choose infectious disease?
So that's a great question. I've been in infectious disease for about 20 years, and infectious disease as a field is very interesting. It's a lot of detective work, a lot of listening to patients combined with diagnostic testing. Many things are treatable, and people get better. So it's very rewarding in that sense. For things that aren't treatable, there's great research that can be done. So I think the field overall is a really interesting field.
Nice. So obviously when we started recording this, it was way before everything that's happened with COVID-19. So maybe just to give listeners a little bit of a primer, since, I assume everyone knows what COVID-19 is by now, but we've been kind of traveling back and forth through time in this season. Can you explain to us what COVID-19 is?
Sure. So COVID-19 is a coronavirus. Coronaviruses have actually been around for a couple of hundred years. And for the most part, they cause the common cold. This is a new type of coronavirus that the world has not seen, so people don't have immunity to it. It's also a little bit different than the common cold coronaviruses because it seems to be affecting more than just the respiratory tract. We're seeing full-blown systemic disease in such cases with kidney problems, neurologic problems, and also, interestingly, clotting issues. So this is definitely not your common cold virus.
And for the neurological issues and the kidney issues, are those for people with pre-existing conditions, or is it anybody?
It can actually be fairly healthy people. So you don't have to have a pre-existing condition to develop these neurologic issues. We're also learning the long-term effects of COVID as well as time goes on. So I think we are learning a lot more about this virus. Anyone can get the coronavirus. It spreads by droplets and contact, just like any other respiratory virus. People who are at risk seem to be those that are older, so over 60, those that have pre-existing conditions like hypertension or other comorbidities. Some people have done research into blood type, and there's some thought that certain blood types are more impacted. There's research being looked at with regards to people's genetics as well.
Oh, interesting. Yeah, I heard the blood type thing because I think I'm one of the blood types.
That's at more risk?
Yeah.
Ouch.
So A blood type is supposed to be more risky than O blood type. So, but I think that kind of research is fairly preliminary at this point, and I think we'll find out more as time goes on.
For sure. I think everyone also in the general population is seeing how science kind of works and how research works. And everyone's like, well, they said this and now they're saying this. And like they said this, and they're taking it all everything at face value, which is like
literally.
Yeah, very literally.
Yeah.
And I think it can get a bit difficult for people to manage the information.
So we have to take some of those studies with a grain of salt. They have to be interpreted by the scientific community. I mean, there were a lot of studies in the beginning that had, come out when COVID was just starting, which, have now been, in a sense, debunked or refuted. So definitely, yes, we're all realizing how research works.
Dr. Kumar, so from when you started before COVID, how has your day-to-day changed from then till now? Any positive or negative changes?
Right. So definitely the world has changed for everyone. At the hospital, safety is really paramount. So on a day-to-day basis, something that has changed is that we're all wearing masks and shields in day-to-day interactions with patients as well as colleagues. Masks are the norm now, even in non-patient areas. There's been a lot of time spent in designing safety protocols with regards to screening staff, with regards to screening patients. As you know, most of our meetings are now remote. We're using MS Teams or Zoom for our meetings. I have to say it's difficult not to be able to see colleagues in person.
Yeah.
Because there's a lot of socializing and a lot of networking that goes on when you see people in person. I think, though, one of the amazing things that has happened in this COVID era is that many researchers have turned to finding a cure for COVID. So this is probably the most concerted effort that I've ever seen in the last 20 years, where we are all working towards a common goal. Mm-hmm. And I think that is truly exciting. It's really brought the research community together.
Mm-hmm. Mm-hmm. When we first started through COVID and those first 2 weeks when everything was just so hectic, how was that for you?
So a little bit scary.
Yeah.
We didn't really know the full story behind COVID. We didn't know the full range of clinical presentations that COVID could present with. And we were just trying to develop our screening protocols at that time. So it was a time of uncertainty, mm-hmm. I would say. But I think we took a step back. I think we reviewed the scientific literature. We figured out the right path to screening. Our laboratory really ramped up testing. And I think it's been huge progress actually ever since the first 2 weeks. It's leaps and bounds, actually, the amount we've learned and the amount we've been able to ramp up resources in keeping things contained.
Mm-hmm. Yeah. I feel like it was just that time, that first 2-3 weeks, everybody was just on edge and it felt like it was just nonstop.
I think there was a time where things were literally the weekends and weekdays were just blending into one. The days and nights were the same, and many of us were up late at night. We were on remote calls all weekend. It was like nonstop. And I think since then, now that we have things a bit more figured out, it has calmed down. I think now at least the weekends are a little bit sane.
Yeah, I'd say so too.
Yeah, I think everyone was having that. I mean, obviously it's different in the hospital, but I think everyone was having some of that. Just having worked from home since March, it's like, oh, it's the weekend. Great, I guess. What's the difference?
Exactly.
Not even just in the hospital, but in those 2 weeks, big companies just having to literally turn their lives around. And it happened in the split of a second where everyone's like, okay, we have to come up with a plan, and everything was changing every 5 minutes. Yeah. Okay, we need to wear masks. Nope. Okay, now we need to wear shields. Okay, now we need to do this. So it was very uncertain is a very good word. Before it was switched overnight, and now it's a little bit more controlled, right?
Yeah. Mm-hmm. So I think the uncertainty, the anxiety, not being able to even socialize.
Right.
Not being able to see your family or your elderly parents, not knowing as healthcare workers that you could contract COVID in the hospital and then take it back to your family. Just all that uncertainty was, it really takes a toll on people.
Terrifying.
Yeah, for sure. Can I ask what your routine is once you get home from the hospital? Do you just wash your hands like everyone else, or do you
step into a...
Yeah, you wish you had one of those decontamination showers.
The second you walk in the door.
Yeah. So I think it depends if I've been seeing patients that day or if it's just been a day at the office. So now if I have been seeing patients, we definitely change once we get to the hospital, change clothes and shoes and so on, put on a lab coat, put on the mask and shield and hand washing. And then once we're done seeing patients, you're changing back into your clothes. So you're not taking your scrubs outside the hospital and changing your shoes and stuff. So I've got a set of sort of scrubs and clothes in my office. And then after going home, definitely, washing hands and taking a shower and changing clothes again.
Right.
So there's a lot of clothes changing and clothes washing going on at home, I think. Yeah.
Okay. That doesn't sound too bad. There's no like incinerator involved, right?
No, not really.
That sounds about right. I do the exact same thing. Like I put everything in a plastic bag and I take it home at the end of my 4 shifts, and then they go into one load and like sanitize on their own. And
exactly.
Yeah.
So I guess going back to those initial 2 weeks when everyone was a bit panicked, can you explain why transplant surgeries were canceled? Can you get like COVID from an organ transplant? Are post-transplant patients higher risk than the general population?
Right. So I think first the issue of why surgeries were postponed. So initially, the big issue was that of hospital capacity. Because things were so uncertain, we weren't sure that we would have enough beds to support a surge of COVID patients. If we had a large number of COVID patients, we would need hospital beds, we would need ICU beds and ventilators. We saw that was happening in New York, and so we were concerned that this would happen here as well. So certain transplant surgeries, especially heart and lung surgeries, heart and lung transplants need ICU care for a few days after transplant. So there was concern that we wouldn't have enough ICU beds. The other issue was that we needed to figure out how we can ensure a safe environment for living donors and also for transplant recipients who are coming in for their transplant. We also didn't know at the time if there would be a risk to taking someone, giving them a transplant, making them immunosuppressed, and then putting them out into the community where there's a lot of COVID circulating. And what would happen if an immunosuppressed person contracted COVID? Would it be worse? And so there were a lot of factors, I think, that went into postponing surgeries, especially transplant. With regards to if you can get COVID from an organ transplant, that was important because we thought theoretically you could at that time. And so although I have to say that so far there has been no case of what we would call donor-derived COVID. There's actually been no case. We did spend a lot of time looking at our donor screening protocols. So we held a lot of meetings where we would talk about donor testing and how we could ensure that there is no donor that has COVID that we're procuring organs from, because that's dangerous in terms of transmission to not only the recipient but also to the transplant team who's doing the operation. Yeah. Mm-hmm. So we came up with a clinical screening tool. So a number of questions where we could screen the donor in terms of their travel history, their contact history, their symptoms. And we also came up with testing. So now what we're doing is we're doing at least 2 COVID tests on donors, an upper respiratory COVID test and a lower respiratory COVID test. And I believe that with clinical screening and PCR testing, we have made donor-derived COVID transmissions as safe as possible.
Right. And for deceased organ donation, I guess they just stopped collecting organs during that time, or how were they testing those?
So we never stopped transplantation.
Yeah.
We never completely stopped transplantation. So what we were doing was in deceased transplantation, we did the clinical screening and we did at least 2 COVID tests, upper and lower respiratory COVID tests. For living donation, what we've done is we are doing a COVID test, an upper respiratory COVID test in living donors in the 48 hours prior to donation, as well as clinical screening, of course. So I think that has made things very, very safe. We are asking our donors to, ensure that they socially distance and to stay at home prior to donation as well.
Mm-hmm. And just for the non-medical people, including myself, is the upper respiratory test, is that the swab?
That's the nasopharyngeal swab. Yeah. So upper respiratory nasopharyngeal swab. The lower respiratory test is for deceased donors. So that's a bronchoscopy or an endotracheal aspirate. So not as much as a bronchoscopy, but still a lower tract, a lower respiratory specimen. So with regards to blood tests, what we know is that very few donors, if any, are positive in their blood. And the numbers that are quoted from the literature are around 1%. And these are not 1% of organ donors. These are 1% of people who have COVID and are in the ICU. So, and those people also have a positive nasopharyngeal swab. So a blood test would be very low yield in donors if you're not getting a positive nasopharyngeal swab as well.
Okay.
So it's best just to do the nasopharyngeal swab and the lower tract specimen as well.
So when they test blood, is that testing immunity as well?
So
or that's different, right?
Right. So immunity testing is different. So there's two types of tests. There's the diagnostic test, which is the PCR, which tells you if you have COVID right now. Then there's the immunity test, which tells you if you've had COVID anytime in the past. Mm-hmm. It doesn't really help to tell you if you have COVID right now, because you could have cleared COVID and be fine as an organ donor, but you may have had COVID in the past and cannot transmit it. Well, you can't transmit it if you have had it in the past and cleared it. So you can only transmit it if you have it actively, which we can pick up through a swab.
Sorry, one more time.
Yeah.
You can only transmit it if you have an active case of COVID.
Right.
Versus if you have had it in the past and you have immunity to it, you cannot transmit it.
Correct. So if you have immunity to COVID and you don't have a positive PCR test, it means you don't have an active infection.
Right.
And so therefore you cannot transmit it. So the only thing immunity tells you is if you have had an infection in the past. Mm-hmm. Now, you may have had that infection 2 weeks ago and have immunity. But if you've had an infection 2 weeks ago, you may also still be active and pick it up on a swab.
Mm-hmm. So, and once you have it, you can get it again though, can't you?
So that's something we're trying to work out.
Okay.
It's very rare that people have become positive again on a swab. So once people clear their swab, it should be cleared completely and they're no longer active and they can no longer transmit. There is this small proportion of people who sometimes have a positive swab a couple of months after clearing it, and we're not sure what that means. That virus may actually not be a replicative virus, which means that virus may be a dead virus.
It's dormant, right?
Or it's dead.
Okay.
It's not dormant. It's just dead virus particles that we're finding.
So all the talks they had about kind of, having immunity passports and those people would be able to move around, the city freely, like, is that still a possibility?
So there's a number of things that need to be clarified before immunity passports can actually
be a thing.
Be a thing. One thing to clarify is, does immunity mean that you cannot get COVID again? So I think that needs to be clarified. The second thing is, how long does immunity actually last? So if immunity lasts 2 or 3 months, then could you get COVID again after that? Mm-hmm. And then the third thing is, if you have immunity, how high does it have to be for you to be protected?
So one of the things that's going through my head right now, and this might be comparing it to a very different ball game, but this is how I'm understanding what you're talking about. Is it similar to chicken pox in a sense that when you get chicken pox, when you have an active infection and then it kind of lays dormant in your body for a significant amount of time until it can, like, not saying that COVID can, like, obviously come back in a different form like shingles, but you have immunity to it in that sense?
So COVID is actually a very different virus than chickenpox.
Yeah.
So chickenpox, right. So chickenpox is a virus that once you get it, it remains dormant in the body and then it comes out, in periods of stress or, in periods of illness as shingles. So that's a different kind of virus. Those are viruses that remain dormant. Respiratory viruses in general are viruses that do not remain dormant. You get them and then they're gone. They're generally not dormant. COVID is a coronavirus, and which is a respiratory virus. So we think it does not have a dormant stage. But the thing about respiratory viruses is that, as I'm sure everyone knows, you can get them over and over again. You get colds over and over again. So the question is whether this coronavirus will be something that people will get over and over again, or will it be a one-time thing? And I think part of that is that respiratory viruses in general do not create good immunity. And that's why people get it over and over again. We're not sure about this with COVID. Will COVID have some kind of lasting immunity, or will it be that it's something that people can get over again? And I think only time will tell.
Right.
So why are some transplants considered elective? And when are they life-saving procedures?
So I think I will answer that and say that no transplant is actually elective. But I think what we can do is classify transplant by priority, and those that are imminently life-saving, and those would be the highest priority, and those that can wait but still need to be done. So when COVID first came about, in those first 2 or 3 weeks of COVID, we had to prioritize transplants. And until we made sure that transplantation could be as safe as possible, and that we had the hospital capacity to do transplants.
And so we kind of touched on this a little bit, talking about transplant recipients on immunosuppressants. So knowing that these drugs weaken your immune system and that a second and third wave of COVID seems, statistically imminent, what does a new normal look like for transplant recipients?
So I think everyone has to be careful now and going forward. There's a new normal for everyone. I think for transplant recipients, wearing masks, good hand washing, and social distancing, like avoiding crowds, avoiding large gatherings, I think that will continue for some time, as I think it will for everyone, until we have a better handle and control on this virus. So I think there's a new normal for everyone as well.
For sure. And a lot of the recipients I've talked to as well, this isn't that different from their day-to-day lives, what they're being asked to do. So
true.
Yeah. Maybe we're all just living at their normal now.
I was just about to say that.
Yeah.
And after speaking with some patients, they're not as in shock factor about the new practices that the world has implemented. They're like, oh, I was taught this from day one. Like, I've always been like this, especially lung patients. They're like, oh, I know, I've always been like this. I've always had to socially distance. I've always worn a mask. I don't go in elevators that are more than like 3 people. So they kind of already knew all these things. So it's not as much of like a shock factor to them because they've always had to practice that way.
For sure.
I think one of the things that maybe has changed a little bit is how we as physicians are seeing patients. right? We're using a lot more telehealth, which we were using before for patients that lived at a distance, but we're doing that a lot more now, even for people who, live close by. And I wonder if that will also be a new normal. And I guess we'll find out.
Mm-hmm.
Yeah, for sure. I think some of the questions that I'm seeing on social media, or that I was initially seeing, are a bit more, I don't know, they're very anxious questions, or questions that come from a very anxious place, just like fear about recipients asking questions like, will I ever be able to go outside again? If I get COVID, do I even stand a chance? Like all this kind of stuff.
So with that being said, do transplant patients present different symptoms than a healthy individual?
So from what we've seen, transplant patients will present very similarly in terms of symptoms to the non-transplant population. So the symptoms are, as we know, primarily cough, fever. Fever may be slightly underrepresented in transplant recipients, so they may get less fever, primarily because of the immune suppression. But other things like cough, shortness of breath, body aches, headaches, those are still very prominent symptoms. And then the question of, are transplant recipients worse off if they get COVID than the general population? What we have seen in the medical literature is that there does seem to be a higher complication rate in transplant recipients. However, I will put a caveat to that, in that the medical literature sometimes reports only the hospitalized patients and the more severe patients. We still don't have a lot of information on what COVID looks like in all transplant patients. I think we have information on if a transplant patient gets admitted to hospital, what it looks like at that point. But there may be transplant patients out there that have had some mild symptoms and maybe never came to medical attention, just maybe put up with it and got over it. And so there is likely a population of those people who've had those mild symptoms out there that we don't know about. And I think one way to figure that out is to do antibody studies and to take blood and see if there are people who had COVID, but they weren't sure if the symptoms were so mild that they didn't know, or just never came to medical attention.
Mm-hmm. Is there any research yet about asymptomatic people and why that's how the virus presents in them?
So there has been research into asymptomatic people. There is a proportion of people that is asymptomatic, and I think we're not sure why those people are asymptomatic. So there have been studies done that show that the antibody response may not last as long in people who are asymptomatic. So this is very preliminary, but it's possible that if you have milder symptoms, your immunity may also not last as long.
Interesting.
That is really interesting.
Really interesting. Yeah. Huh. That's a head scratcher.
So it was predicted that transplant patients would be severely impacted by COVID because of their pre-existing conditions. So the infection rate for transplant patients turned out to be pretty low and still is pretty low. Why do you think that is?
So I think, transplant recipients are being very cautious. I think people are very educated. I think transplant recipients are not traveling. They are practicing social distancing, wearing masks, maybe having other people do their, outside work like groceries. And I think that's kept the rates low. I would just say one thing that I have seen is that family members may bring COVID home to transplant recipients. And I think that's where we need to be a little more careful, especially where family members are going out. Somebody has to go out to get the groceries. Somebody has to go and work. That may be a place where, people may need to be more careful in terms of bringing COVID home to someone that has low immunity.
I was always wondering this, working in the bedside. And I mean, when things were crazy and hectic and we were all expecting Toronto to kind of be parallel to what New York looked like, and working on the ward, just being like, okay, like when any day now, we're just going to get this influx of patients. We were just waiting for it. And not like it's a bad thing, but why aren't people getting as sick as we had thought? Yeah. And the only answer that I could think of was merely the fact that for their practices, and that they knew previous to this how to distance and do all these things like we talked about, all these safety measures, and they just like ramped it up. They're like, no, yeah. It's merely for the safety practices that they think they've been implemented, which is pretty incredible.
Yeah, I absolutely agree. I think our public health system has actually kept us very, very safe. Mm-hmm. You know, I think we learned a lot of lessons from the first SARS in 2003. And because of that, made a very strong public health system. I think people remember 2003. And I think we've just, as a community, I think we've done a stellar job at
I'd say so too.
Preventing COVID. Considering what's going on even right now in the United States and other parts of the world, we're in a very decent place, I would say.
I'd say so too. I've heard from like older nurses, previous nurses, when they put out the call, like, anyone want to come back? And they're like, I already did SARS. They're like, I can't do that again. But people have learned specifically from SARS what it really takes in order to kind of keep this virus at bay.
Right.
From both of your perspectives, what would you say the biggest difference is in between handling COVID and handling SARS?
I can't speak on it. I was like 12. I'm sorry. I was in the grade 7.
2003.
Yeah, I was like literally like grade 7.
Yeah, I was 13.
So I can't lie. I just heard from
Dr.
Kumar.
Yeah, I was a little bit older. So what have we done differently in handling this versus handling SARS? So one very important thing we have now is testing. So we were able to very rapidly develop testing, and I'm talking about PCR testing, to detect cases in the hospital and in the community. During SARS, it was actually much more difficult to get a test for SARS.
Interesting.
We were diagnosing people with SARS based on clinical symptoms. So if somebody came in with severe pneumonia, they had traveled, or they had been in contact with somebody else with severe pneumonia, they were a probable case of SARS. Now we have a test, and we can do a swab, have the results back very quickly, and know if people have COVID or not. I think that's made a huge difference, you know, in terms of detecting cases, tracing contacts, and then isolating people who have been in contact. I think today's testing and technology has actually made a huge difference. The other thing we have today is social media, and a way to disseminate information so quickly that people are very educated. They know exactly what's going on a day-to-day basis. So I think that's another thing that has made a huge difference today versus in 2003.
For sure, yeah. In 2003, there was definitely no Zoom, but was Skype even a thing yet? Like,
don't think so.
Yeah.
It was like MSN.
Yeah. Oh, yeah. MSN.
Yeah, MSN Messenger.
MSN Messenger.
Oh, boy. Yeah, that would be hard for like virtual birthday parties and stuff on MSN Messenger. Not quite the same.
Yeah.
So what kind of supports are available to transplant patients, and or what's any advice that you would offer them re-COVID?
So with regards to supports for transplant patients, I think for transplant patients, call your coordinators if you have any questions about your immediate health. Call your physicians. There's also mental health support out there as well. There is a website for the transplant societies, so the Canadian Society of Transplantation as well as the American Society of Transplantation. Both have links to FAQs, frequently asked questions that transplant patients may ask. that you can go and look at. Both, are updated regularly. So I would encourage people to go on that website if they have any questions, but definitely talk to your coordinators and physicians. And people at your transplant center are always ready to help.
I think another thing that I notice as a nurse is personal hygiene. We all assume that people have the same personal hygiene practices, which is just not the case. But sometimes they don't necessarily realize that they need to ramp up their personal hygiene, like brushing. They're really basic things, but I don't think people recognize how important they are for killing bacteria, like showering every day and brushing your teeth and mouthwash and washing your face. It's not, it goes beyond just like washing hands. It goes like to every level of personal hygiene in like your house and like your bed sheets and stuff like that. Just from what I've noticed for seeing people live in the hospital.
There's definitely an emphasis on all personal hygiene for sure. I think people are definitely washing their hands a lot more and carrying hand sanitizer. And I wonder what effect that will have on other respiratory viruses, like influenza, like there's many other respiratory viruses. And I think what will be interesting to see down the line is if all these things that we're doing are actually going to be able to prevent other respiratory viruses as well.
Yeah, absolutely.
That's interesting. I've also heard the opposite, that sanitizing your hands too much, people are worried about creating superbugs or things like that. The look you gave me made me really nervous about saying superbugs. Is that like a pop culture term that a pop science term I should not be using?
So I would say, in hand sanitizer, it's predominantly an alcohol-based hand sanitizer. So could bugs develop resistance to that alcohol-based hand sanitizer? It's unlikely that would happen.
That makes me feel so much better.
Yeah. Definitely we see resistance with antibiotic use and so on, and those are very specific mechanisms. But I think it's just a little bit harder, I would say, to develop resistance to hand sanitizer, especially if there's a good amount of alcohol in there.
Oh, okay. What would you say? At least 70%?
At least 70%.
At least 70%, in my opinion. I've been at some grocery stores and they're like, you use this alcohol hand sanitizer, and I smell it. And I'm like, I can't smell anything. I need to be able to smell and be like, oh, geez, in order for it to say it works.
That's the test.
That's my test. I'm like, oh gosh, that's awful. Have people in your life circle treated you differently, knowing that you're a healthcare provider, in regards to you being more, air quote, more exposed?
I think people really appreciate what healthcare workers do. I think that's one feedback I've gotten, just a lot of thank yous in terms of being at the front line and doing what we do. I'm always being asked questions about COVID because I'm an infectious disease physician. So questions from friends and family, constant questions about what's going to happen, when will the vaccine come out, should I get the vaccine when it comes out? That's those sorts of questions. I don't think anyone has been afraid to see me because I'm quote unquote exposed, because we all take very, very good precautions. We're practicing social distancing, as everyone is. Healthcare workers are practicing social distancing just like everyone else. We're also remaining vigilant regarding our own symptoms and how we feel. So every day, how are we feeling? We're going through a symptom checklist, making sure we're feeling good. So I don't think on a personal level, I don't think I've gotten any scary looks that, oh, I want to stay away from you because you're a healthcare worker dealing with COVID patients. Yeah.
You should test it out wearing your scrubs in public.
Yeah. People just get out. I actually had a friend the other day. He was like, oh, what do you do for work? He's like, what do you do for work? I'm like, oh, I'm a nurse. And he goes, oh my God, you're on the front line?
This is a new friend, I assume.
Yeah. He's like, you're a first responder? And I'm like, no, I'm not a first responder. I'm a nurse. He's like, oh my God, you're a first responder. He's freaking out. Thank you for what you're doing.
Yeah.
Yes.
No, it's like the reception from the community has been amazing, actually.
Yeah. It's nice.
Yeah,
it's
very
really
nice.
And we're all kind of like waiting for the vaccine. Once we get the vaccine, are all our problems with COVID solved?
Right. So I think, again, there's a lot of questions out there. How good will the vaccine be? I think that's an important question. What will the vaccine uptake be? So will people get the vaccine once it's out there?
Will they comply?
Yeah. Will they comply with getting the vaccine? But also how well will the vaccine work in the general population, and how well will it work in transplant patients? I think that remains to be seen. Many vaccines don't work as well in transplant recipients.
I was going to ask.
But if, for example, even if it doesn't work as well in a transplant recipient, we know that for many vaccines there is a partial effect. And if people in the household get vaccinated and the vaccine works well in those people, then there is sort of a circle of immunity that forms. And so then you can't bring home COVID to the person that's immune suppressed.
That's a good point.
It's kind of similar to masks. It's like you're not necessarily wearing a mask to protect yourself, but you're actually just wearing a mask to protect everybody that you're around. It's the same thing with vaccines. You're not necessarily getting a vaccine just to protect yourself. You're getting a vaccine to protect everyone else around you. And I think that's the message that a lot of people have missed in the past when it comes to the flu vaccine. Right. And more like any vaccine, but the flu shot, people automatically go, oh, I don't need it. I don't get sick in a year. And I'm like, it's actually not for you. It's more for the general public.
Right.
It's the same thing with like masks and social distancing, and it's more for everyone as opposed to just being. So I think the biggest hurdle might be that people won't necessarily comply with the actual vaccine.
Right. But having said that, I mean, we're working fast towards a vaccine. There are so many different companies working towards different types of vaccines, all for COVID. And I think, to me, I'm very optimistic that there will be a vaccine very soon.
That's nice and very reassuring to hear, right?
That is nice to hear for sure.
Do you think that anything positive has come from the pandemic? Even though we kind of talked about it, about how it might help with the other respiratory infections, but do you think anything else positive has come from this pandemic?
Yeah, definitely. People are much more educated about preventing infections in general. So that's one thing. I think that the increased use of telehealth might be something positive that stays with us. And using technology in general, and how we realize how much we can accomplish doing remote meetings. We can actually accomplish a lot. That might stay with us to a certain extent as well.
Mm-hmm.
Yes.
So I think some good things like that have come out, not to mention the impact on the environment and things like that.
Yeah.
So.
And has COVID sparked any interest in your study of medicine for the future?
I think, as for myself, I was working in the respiratory viruses field prior to COVID. And so I think it's a natural thing to move the research towards COVID. So we're doing some research in COVID. We're actually looking at the immune system of transplant recipients who have gotten COVID to see how high the antibodies are and how long they last. So those are some very exciting sort of research venues that we'll be exploring in the future.
Yeah, it's a very interesting time to be in medicine.
Well, hopefully this will be a once in a lifetime thing, and
I hope so.
Mm-hmm.
And that's it.
Yeah, absolutely. Yeah. Thank you so much.
Thank you so much.
Thank you.
Thanks for listening to this episode of Living Transplant. If you have questions or suggestions for future episodes, email us at livingorgandonation@uhn.ca.
Don't forget to subscribe, rate, and review Living Transplant on iTunes, Spotify, or wherever you listen to podcasts.
And follow us at Give Life UHN on Facebook, Twitter, and Instagram.
See you next time.